all of you. I take this special opportunity to moderate a session on liver transplant by Amrita Hospital, Faridabad. And I think two of the three people who are going to speak are my juniors. So it feels like I'm also getting senior now. So the first lecture would be by Dr. Rohit Mehtani, who is a consultant in the Department of Hepatology. The topic would be, when does cirrhotic patient need a liver transplant? Rohit is a junior from UCMS and did his undergraduate from UCMS, MBBS from Indore, DM in PGI. He got the gold medal in hepatology from there and has been a really eminent person in the field of hepatology. Followed by a talk by Dr. Jaya Agarwal. Again, she's a junior of mine from MAMC. She was doing a UG when I was doing MD from there. And she's MBBS from Maulana Azad. PG and MCH both she's done from PGI Chandigarh. Sorry, MCH she's done from Amrita Kochi. And she has a gold medal in MBBS, MS, MCH. And she's been a gold medalist throughout. And I just came to know she's also a daughter of a legendary surgeon of South Delhi, NCR.
Dr. Jaya Agarwal, okay? Not Shweta Mallick.
Followed by a talk by Dr. Shweta Mallick, who will be talking about robotic donor hepatectomy with a video demonstration. And she's done her UG and PG from Videhi Institute of Medical Sciences, Bangalore, MCH and GI surgery from Amrita Kochi. So I welcome all the three esteemed speakers to speak, and I welcome Dr. Rohit to talk about his topic. Thank you. These are not my words which I am going to speak, but I have been asked to tell you to please maintain decorum while the meeting. Thank you.
Thank you, Dr. Shubham, for the kind words.
Rohit, 1 minute more. Again, not my words. Please stick to the timeline of the meetings. Thank you.
Maybe less. Very good. Thank you. I'm Dr. Rohit Mehtani. I'm assistant professor in the Department of Hepatology at Amrita Hospital, Faridabad. I will just be covering the basics of liver transplant indications and when should a patient be advised to undergo a liver transplant. So he is Professor Thomas Charles. He is the father of liver transplant surgery, and his journey has been difficult and his journey has been difficult to start with, but at the same time inspirational also. His first 5 liver transplant patients did not survive for more than 23 days. Then gradually he published the largest series in liver transplant of 1179 patients in 1989 with a survival of 1 year of 73%. Even in his autobiography he mentions that he was striving for liberation for his whole life, and he hated performing surgery because of the outcomes which were followed in the initial days. So whenever we advise a patient transplant, before advising we follow these 5 rules. So is there any alternative treatment for his liver disease apart from a liver transplant? So can he be managed with anything else? Suppose if a patient of cirrhosis has refractory ascites with good liver function, the middle score is 10, 11, less than 15. So there are other ways to manage, like a TIPS stent, and the transplant can be delayed. Then can the patient survive the operative and the post-operative period? So if a patient is very sick on the ventilator with multi-organ failure, he will not be able to survive the post-transplant and the surgery. So for those cases, there is a futility of liver transplant, and we don't advise liver transplant for them. And does the patient have any other comorbid condition that precludes the liver transplant surgery? Suppose he has an ischemic heart disease with a poor ejection fraction. Then there is no point of doing a liver transplant, because his post-transplant life will not be, he will not be able to achieve the function which he should normally have. Or if a patient with stroke who is bedridden, he cannot have a meaningful life after liver transplant. So we don't advise transplant surgery to them. And can the patient comply with complex medical regime and the strict follow-up which is needed? So psychosocial counseling is a very important part of the liver transplant counseling. So if a patient has a good social support and does not have any other or psychological issues which preclude him from following the medical therapies which are needed after transplant, then also the transplant is not advisable. And is the recurrence rate of disease in the liver transplant acceptable? So many diseases recur after liver transplant, like non-alcoholic fatty liver disease, or risk of alcoholism after liver transplant, or there are autoimmune liver diseases which recur after transplant, but their risks are more or less acceptable. This is more important when we are doing transplant for malignancies, for liver cancers. So the cancer has to be of a specific size and it should be limited to the liver, then only we advise liver transplant. So briefly, speaking about the indications, it can be done for acute liver failure, in which the patient develops sudden onset jaundice, coagulopathy and encephalopathy without any pre-existing underlying chronic liver disease. And also hepatic artery thrombosis within 14 days of liver transplant. So that also qualifies as an indication for re-transplantation. Then there can be chronic liver diseases like alcoholic liver disease, non-alcoholic liver disease, autoimmune liver diseases, Wilson's diseases, hemochromatosis, then congenital diseases. Then few tumors like hepatocellular carcinoma, hilar cholangiocarcinoma, neuroendocrine tumor, and few special indications of colorectal liver metastasis. So even in a metastatic malignancy, we can do liver transplant, but it should be there are specific indications like it should be an isolated metastasis to the liver, and the primary has to be taken care of. Then we can do in the CRM also. And then variant syndromes where we offer mild exceptions, like chronic hepatic encephalopathy, refractory ascites, hepatopulmonary syndrome, familial amyloid polyneuropathy, hypercholesterolemia, then there is oxalate neuropathy. Then there are few contraindications of liver transplant. These can be divided into absolute and relative. So if there is an extrahepatic malignancy apart from CRM, that is colorectal, that is an absolute contraindication. Active untreated malignancy is an absolute contraindication. Then intrahepatic cholangiocarcinoma, although there are new studies which are coming up, but it has been traditionally considered as an absolute contraindication. Then there are severe cardiopulmonary diseases like poor ejection fraction or interstitial lung disease with a high oxygen requirement. Then it's an absolute contraindication. Uncontrolled sepsis, active alcohol intake. So we usually follow the 3 months for disease on a liver transplant, 6 months abstinence rule. So a patient should be abstinent for alcohol for at least 6 months before putting him on the liver transplant list. Then AIDS syndrome is a absolute contraindication, while HIV is a relative contraindication. Then lack of social support. Then relative contraindications, advanced age. So although there have been case reports where more than 70-75 years also transplant has been done, but roughly around 65 to 70 is the cutoff for liver transplant surgery. Then extensive portal vein thrombosis, which is where there is no shuntable vein where the anastomosis can be made, so that is an absolute relative contraindication. HIV, then a MED score of less than 15, it is a liver disease severity score calculated on the basis of bilirubin, INR and creatinine values. So MED score less than 15 is a relative contraindication for liver transplants. But there are few exceptions to this, which I will be covering in the next slide. Class 3 obesity, that is BMI more than 40, is a relative contraindication. Although it can be done by a simultaneous bariatric surgery and a liver transplant surgery. So, but it's a relative contraindication. Then psychiatric comorbidities, where the patient will not be able to follow up strictly after the transplant, then also it's a contraindication. So right now we follow MED-based allocation policy. So we start evaluation when the MED score is less than 10 and consider for liver transplant when the MED score is less than more than 15. And now since hyponatremia has a higher risk of waitlist mortality, the MED has been replaced by the MED sodium score in 2016. So the follow-up of patients with cirrhosis is based on the MED score. So for a MED score of more than 25, the OPD follow-up or the lab test has to be done every weekly. For 19 to 24 med score, we follow them monthly. For 11 to 18, we follow them every 3 months. And for a med score less than 10, yearly follow-up is also sufficient. But all patients with cirrhosis should follow at least 6 monthly screening for hepatocellular carcinoma by an ultrasound and an AFP test at the least. These are few mild exceptions like HCC. There are few criteria like the Milan criteria and the UCSF criteria where there should be a single liver lesion less than 5 cm or 3 lesions up to 3 cm each. Then we can consider them for transplant. Then we have moderate to severe hepatopulmonary syndrome, portopulmonary hypertension with a mean pulmonary artery pressure less than 35. These are few conditions like familial amyloidotic polyneuropathy and primary hyperoxaluria and cystic fibrosis. So in these three conditions, there is no liver disease as such. The patient will be fine from the liver side. There will be no jaundice, no ascites, no complications of liver disease. But the genetic defect is in the liver. That's why liver transplant is advised. So in this patient, the patient will have polyneuropathies, hyperoxaluria, there will be chronic kidney disease, patient will be on dialysis. But if we do kidney transplant alone in this case patient, then after few years the new kidneys will also get damaged and the patient will come back again on dialysis. So they are advised for a primary hyperoxaluria is an indication for simultaneous liver kidney transplant. And then hilar cholangiocarcinoma. So these are just the criteria which we follow for this is the King's College criteria for liver transplant. Most important thing is if the patient has an INR of more than 6.5, there is a high likelihood that the patient will not survive without a liver transplant and he should be referred for a liver transplant.
Rohit, 1 minute left.
Very good. 2 slides. So this is the Milan criteria for HCC. So single lesion less than 5 cm or 3 lesions less than 3 cm each with no vascular invasion, no extrahepatic spread. So this is the most commonly followed criteria for liver transplant for HCC. And we have acute on chronic liver failure. It is a new concept which has come up where patients have an acute insult in a background of underlying chronic liver disease. Acute insult can be hepatic or extrahepatic like viral hepatitis, alcoholic hepatitis, or any other infection like patient develops a pneumonia and then secondary to that he develops liver failure because he has underlying cirrhosis. So we can offer transplant in them also. The key point is that the patient should not have multi-organ failure. If there are more than 2 or 3 organs involved like pulmonary failure, kidney failure, circulatory failure, then transplant is not advisable. And they have to be stabilized medically first and then transplant later. Skip this. This is our team at Amrita Hospital, Faridabad. This photo was clicked after the discharge of the first liver transplantation which was done robotic. The donor was done robotically. And thank you. I'll have to take some questions.
Second speaker, please. I think we have Dr. Jaya now, and who can be a liver donor. Thank you, Rohit. Please join us on the dais. Thank you.
Good evening, everyone. Thank you for such a warm welcome. I'm from the Department of HPV Surgery and Solid Organ Transplantation at Agarwal Hospital.
Also, mic thoda.
Is it any better now?
Mic man, near your mouth.
Maybe nearer.
Yeah.
You have a mic.
You could stick it here.
Try that.
Very good.
No, it's okay.
Today evening I will be talking to you about who could be a potential liver donor. That's a question that is that comes across each time we have to counsel a family or when we even meet doctors who are counseling cirrhotic patients. So I hope I can stick to the time and justify the topic. So liver transplantation is synonymous to teamwork, and we're proud at Amrita Hospital, Faridabad, that we come with a team that has 25 years of experience in handling solid organ transplantation. Till date, we have done over 2,000 liver transplants and multivisceral transplants, which include simultaneous liver kidney transplant, simultaneous pancreas kidney transplant, as well as small intestinal transplant. So our team is headed by Dr. Shubham, who did the very first robotic donor surgery in the country in 2018. And since then, we have done about 400 robotic donor surgeries. That puts us at the top of the list in India and second highest in the world. So as I mentioned before, every time we counsel a family for transplant, the very first question that comes in is, who can be a liver donor? A donor is a normal person who, in order to save lives of their near and dear ones, comes forward and undertakes that major surgery so that they can save a life. So for us, it's paramount important that the donor life should be at safety. So let's talk about who is an ideal donor. A donor should be a normal person who is between 18 to 55 years of age, who is blood group compatible to the recipient and who is related to the recipient. The donor should not have any major uncontrolled comorbidities or any major addictions. So to ensure all of this, once a donor walks into the OPD, we have a protocol as per which we evaluate the donor. The step 1 is some basic blood tests and blood group. The step 2 is a radiological evaluation of the donor, which includes a CT as well as an MRCP to assess the vascular as well as biliary anatomy. And finally, the donor goes through a multidisciplinary systemic evaluation. After all of this, once everybody has cleared, we say that the donor is safe to undergo the procedure. During the surgery for an adult, we usually require right lobe of the donor, which is about 50 to 55% of the liver, and that is implanted into the recipient. Liver is the only organ in the body that has the beauty to regrow back to its normal size within 3 months. But still for the donor, it's a major surgery, and there are complications, although a small percentage, but still they can be associated, and we clearly inform them prior to the surgery what could be a minor complication, what could be a major complication. After the entire family, the donor is on the same page, only we go ahead with the surgery. So there are a lot of myths about who can be a liver donor, and I will try to clarify some of those facts. One common question that people misunderstand is that donor needs to be of the identical group as the recipient. It is not the identical group. The donor has to be of a compatible group. As we consider for blood donation, blood group O is a universal donor, blood group AB is a universal recipient. So suppose if we have a recipient who's of A group, either A or O could be a potential donor. Recess positivity, negativity does not matter in cases of liver. Donors commonly ask us that after the surgery, what are the usual restrictions that they have in their lifestyle and whether they would have to take any medicines lifelong. So if the donor goes through the perioperative period without a major complications, the donors can lead a normal, healthy lifestyle as they were prior to the surgery, and they do not need to take any medications lifelong, unlike the recipients who need to take the immunosuppression throughout their life. Many young females, unmarried, come forward and are potential donors for their loved ones. So they have this concern whether post-surgery would they be able to become mothers. So liver donation surgery does not affect fertility. They can undergo a normal pregnancy as well as a normal delivery post-procedure. Another question that is commonly asked is, I cannot be a liver donor because I have some diabetes or hypertension or hypothyroidism. So as long as the comorbidities are well optimized and controlled, they can be evaluated as potential donors for their relatives. Also, a few people come forward saying that we've undergone a previous abdominal surgery in the past, so I am unfit to be a liver donor. But previous abdominal surgery is not a limitation provided there is adequate time gap between the first surgery as well as the donor hepatectomy. So we at Amrita Hospital run the concept of liver clinic. Whenever the patient comes into the hospital, under one registration, he can meet the hepatologist, the transplant surgeon, the nutrition as well as the transplant coordinator, so that they have a whole idea about how the pre-transplant workup is going to be, what are the legal requirements for transplant, as well as what the surgical procedure is going to be. So that our aim is to make the liver donation process safe as well as smooth. In this last slide, I would like to share some of our success stories. The very first picture is of a couple in which the wife agreed to be a donor for the recipient. She underwent a robotic donor hepatectomy, had an uneventful surgery and an uneventful post-op, was discharged by day 7, and both of them are doing very well.
Very good.
The second is a photo of a young 20-year-old boy who decided to donate a part of his liver for his father. He also underwent a robotic donor hepatectomy, got discharged in 10 days, and within 1 month of the surgery has joined back his college. He's in second year of BCom management. And the final is the most interesting. It's about a 69-year-old lady who is the mother of the patient, and she said, I want to save my son at all costs. Even we were very skeptical of considering her as the donor owing to the age. But she is one of that farmer ladies who walks 3 kilometers every day, does all the farming and absolutely healthy, all departments cleared. We explained them the risks and went ahead, and both of them are doing perfectly well after the surgery. So such success stories keep us driving so that we are able to deliver healthcare at an affordable price. In the end, I would like to thank you all for your kind attention and would like to
I welcome the next speaker, Dr. Shweta Mallick. She will be speaking on robotic donor hepatectomy.
Video will work.
Good evening, everybody. I've been asked to keep it short, so I'm trying my best to keep it short. Basically, Dr. Jaya has already given you a background about how our department works and what we've achieved in the last 25 years. Basically, we are the Department of Solid Organ Transplantation in the HPB at Amrita. We work in both Kochi and in Faridabad. I'll jump to the topic at hand, which is robotic liver donor surgery. So, what's the big deal? This question is something that has been asked to us when we first started out the program in 2018, and we get to hear this question even now quite often. Why are we so focused on doing robotic? So, I think our motivation for starting this program was basically to provide the liver donor with the benefits of minimally invasive surgery. Minimally invasive surgery comes with its benefits, which open surgery, which is done the conventional manner, doesn't come with. For example, the patients would have a smaller wound, early recovery, lesser pain, and decreased chances of wound infection, other wound-related complications. So when we talk about minimally invasive surgery, it includes both laparoscopic and robotic surgery. We found that although the end results will probably be similar, robotic surgery does have certain technical advantages which lab surgery doesn't provide. This is just to give a basic idea about how the robotic system works. This is the Da Vinci exercise system, and it's got three components. It's a patient side cart that you can see here. These are the robotic arms which get connected to the patient via laparoscopic ports. Then you have the vision cart. The last image down there is the robotic console through which the surgeon operates in a remote manner by manipulating the arms through the console. So I will not go into details, but the technical benefits of the robotic system as such is the surgeon is operating in an immersive 3D vision with 10 times the magnification and high definition. That obviously provides enhanced visualization of the abdomen inside. The robot has an end-to-wrist technology which provides us with increased mobility in comparison to lab. This helps us mimicking open surgery in the robot. The high dextration and tremor filtration provides us with a stable operating field. Also incorporated in the exercise system is ICG cholangiography, which you will see in the video later. And it has an inbuilt ultrasound which helps us in tumor localization and tumor mapping. Along with this, robot also has dual console wherein the mentor can teach a potential trainee, and thus there is easier transfer of skills and basically decreases the learning curve. So we'll move on to the video. This is the video of a robotic donor hepatectomy in which we are retrieving the right side of the liver, right donor hepatectomy. This is how the ports are placed in the abdomen, and these ports are then connected to the robotic arms. The liver right donor hepatectomy, first it comes in multiple parts, the steps of the surgery. The first step is to carry out the mobilization of the entire right lobe of the liver, which basically involves freeing the liver from its attachments around the diaphragm. So freeing it from the falciform ligament, the triangular ligament, and all the other loose areolar tissue which connects the liver with the right side. Once the mobilization of the liver is complete from the surroundings, we also develop the plane in the supraclavian part, that's above the inferior vena cava, wherein we could possibly be encountering smaller veins, inferior hepatic veins and the caudate veins, which can be managed quite easily in this platform using clips. Smaller veins can be managed with even diathermy and larger ones with staplers. After the mobilization is complete, the next step is to perform hilar dissection, wherein this is the right side graft, so we delineate the right inflow structures, the right artery, the right portal vein and the right bile duct, before moving on to the next step, which would be transection of the liver. So this is hilar clamping, where we occlude the right inflow structures, and with the help of ICG, the indocyanine beam mapping, we can demarcate the liver into right and left lobes, and that denotes us where the middle hepatic vein plane is. So our transection usually takes place along the middle hepatic vein, where we leave part of the middle hepatic vein with the recipient and part of it with the donor, so that the volume is adequate on either side. In difficult areas like these, which is in the depth of the liver, we feel that the robotic platform is better for bleeding control and suturing in comparison to lab, mainly because of the end-to-wrist technology that the robot offers. Larger veins can be managed with hemlock clips or even with vascular staplers where it is required. So this is the looping and the dilution of the middle hepatic vein in the donor. So for the transection we use energy devices and QSA, which is also used in open, so we are able to replicate open techniques in robot. This ICG delineation of the bile duct, the benefit is that it gives us real-time visualization of the bifurcation, so the error is reduced. And after the duct is divided, robotic suturing is quite convenient to perform. Hence, it can be done with precision, which probably is little inferior in lab. Once the transection is complete, we are ready for the division of the inflow structures. To take out the graft, this is the division of the right hepatic artery. This is where the ischemic time for the graft starts. And the next steps should be in series of quick succession. This is the division of the portal vein between sequentially placed hemlock clips. Once the inflow is divided, then you move on to the outflow, which is either inferior hepatic veins if they are present, or in the vein with the right hepatic vein. We use mechanized endovascular staplers for this. Once it's divided, we take it out by a small penicillin incision. This is the graft. Once it's retrieved, these veins are reconstructed on bench and then taken in for implant into the recipient. So this is this abdomen, how it looks in robotic surgery. In open, we have a big scar, which I'll show later. The next video is of a tumor hepatectomy. We have moved on from doing not just robotic donors, hepatectomy for donors, but also complex tumor hepatectomies. This is a short video which I just wanted to show. As you can see, there is a lesion in the segment 5 of the liver, actively enhancing lesion, probably a HCC. As you can see that the liver doesn't look very good. Some micronodular changes are present, so we wanted to do a non-anatomical liver resection. The tumor is not visible from outside, and we don't have haptic feedback in the robot, so we can't feel the tumor. So for that, what we use is, what comes along with the robot is an incorporated ultrasound. So you can see the lower part of the screen, we have simultaneous images of both intraoperative vision and what is also being shown with the ultrasound. With this, we can localize the tumor exactly, define the margins, and then plan our transection along those margins, maintaining a oncological resection. Also, with the help of ultrasound, we can identify and be careful about the deeper vascular structures which may be encountered during the deeper parts of the transection. In this case, we are using QSA for parenchymal transection. We can also use devices like harmonic and even robotic caniplasia for transection of the parenchyma. Once the transection is complete, again we retrieve the specimen in a bag via a small, either a small midline or via a small penicillin incision, as I had shown previously in the donor. So once the hemostasis is achieved and the without biting, the surgery is complete in a minimally invasive fashion. This image is something that I'd like to show so that you all can understand with clarity as to what is the difference between open and robot. Here you can see in open surgery we have a grossly visible scar which could have potential wound complications like hernia, like hypertrophy, etc. On the other hand, we have a pretty neat small 12 cm incision scar in penicillin, which is more cosmetic and it can be
Thank you so much, Dr. Shubham. It's a proud privilege to be present today for the esteemed faculty which is present. I'd first like to introduce Dr. Manav Suryavanshi. He is head urology, clinical lead uro-oncology and robotic surgery at Amrita, Faridabad. Prior to this, he was the director of uro-oncology and robotic surgery at Vedanta, Gurugram, with an experience of 20 years, gold medalist MCHK in Mumbai. And a comment, it's always, something when a colleague urologist hears good words about another, and for Manav, I must say, from another, I've not seen his surgical work, but I've heard that he's an artist at what he does. So, with these words, I'd like to introduce Manav, and he's going to give us his insights on robotic urology today. In setting up the slides, I'll also introduce the second speaker, which is Dr. Ahmad Kamaal. he can join us on the, he's the senior consultant virologist and renal transplant surgeon at Amrita, worked at IBS New Delhi as associate professor for 5 years, fellowship in kidney transplant at Vedanta, and worked there as associate consultant. And he will be giving us his insights on kidney transplant surgery.
Good evening, August House. This is Manav, and thank you, Vineet, for introducing me as an artist and giving me some performance anxiety. Anyways, so let's talk about robotics in urology. So we have a limited time period over here, but I've been given to understand we have 15 minutes. But the story of robotics goes like this. It started in cardiac sciences for cardiac surgery. The company was going kaput and bankrupt. A gentleman called Mr. Manimenon, Dr. Manimenon, went to the guys to give him a robo, and he was denied. They laughed off. Why a urologist has come? He went to another gentleman called Raj Vatikutti. He was a Malayali and a philanthropist in America and a billionaire, asking him to get him a robo, which he obliged, on the condition that 2 rooms in Detroit Hospital, Henry Ford, will be named as Vatikutti Institute of Prostatectomy. It was named Vatikutti because the Americans could not pronounce Vatikuttil, which was his family name. From here on, we'll start into robotics in urology and a short overview. And my job is made easier by Dr. Shweta, because she's already introduced you. So, how does the pointer work? So, this is what goes into the patient.
Can I request for some silence, please? There's too much cutlery noise, please.
So some small finger-like instruments go into the body from 8 mm keyholes. This is what the assistant looks by the bedside, and this is where the surgeon sits and plays the video game, apparently. This is what would look like in an OR. If you have a dual console, one can be a trainee, one can be the main surgeon. They can change the toggle the instruments in between. The bedside assistant, the keyholes, the patient is lying somewhere over here. So, in this dawn of the robotic era, what are exactly the deliverables, what are the advantages, disadvantages, and open eras? Because everything that comes with its own set of packages is what I'm going to talk about. Yes, sir. Sure.
Yeah, that's fine.
So, if you look at the deliverables, mainly it has gone into the pelvic area, where we have a problem with the reach of the instruments. So, prostate cancers, kidney cancers, bladder cancers, robotic retroperitoneal lymph node dissections for testicular cancers and upper tract urothelial cancers can be done robotically. Not only cancers, but in urology it's a pleasant branch to be in. You can do reconstructive surgeries like pyeloplasties for pelvic junction obstructions, ureteric strictures, reimplantations, body flap, even ureterochelicostomies robotically. I have almost one of the largest series in this country. I stand at 200 adrenalectomies, and even kidney transplant recipient surgeries are getting the benefit of robotic surgeries today. So if we talk about prostate cancer, I'll give you some 1-minute clips of some videos each. However, having said that, men with more than 50 years do get a screening done, or someone having a family history of prostate cancer. So just understand the gist and context. Or an African descent, or with the dawn of the molecular or the genetic era, the BRCA2 mutation. If it runs in the family, you are at a higher risk of having prostate cancers. And such would be the candidates that if someone has a PSA of more than 1 at 40 or 2 at 60, that's a risk stratification that justifies PSA screening today. They get a 2-yearly screening with PSAs. However, if someone has lesser than these values, you can change the distance between the screenings and follow-ups to 8 years. And if you have a limited life expectancy, surely never get a PSA done, because aging will take you over before that. There's a role of MRI too. When we sit over here, it's not only about surgery. You see, before recommending a prostate biopsy today, you must do an MRI prostate with a Pirate scoring, because it helps you target the clinically significant cancer and pick up the sheep and the bulls from each other, and you would like to only target the bulls because the sheeps don't harm. So a 10 to 12 core biopsy and a suspicious lesion on MRI being targeted by the biopsy and ensure all the biopsies that are done, even if you are referring them to someone, should be sent in separate containers for mapping and a better precise surgery. For METs, you would do something like a PSMA PET CT scan. And for a treatment of a localized prostate cancer, you offer robotic radical prostatectomy today along with lymphadenectomies. So, after a radical prostatectomy is done, a PSA level should be undetectable or less than 0.1. And regular follow-ups involve PSA measurements on a 3-monthly journey. So this is how a robot looks from the side. Somewhere the artist in me stood away 10 years back and I drew a rough sketch. And that's the patient in a Trendelberg position so that the bowel goes towards his head side. And this is where the instruments go in and you operate on a small prostate somewhere in the depth. And now I'll show you a small clip of a prostatectomy and the precision with which we can even do very difficult cases. So we are catching the action at a place where we are looking at the seminal vesicles and the pouch of Douglas just next to the rectum and the bilateral vas of the male patient. Sorry, just. So these are the seminal vesicles on the sides, 2 vas, and we are behind the bladder and in front of the rectum. Somewhere you have to realize your eyes can't see and your instruments don't reach. But with the robotic magnification, you do a great job. These are the external iliac vessels. You open the peritoneum and you can pick up lymph nodes from here in a beautiful fashion and almost as much as open surgery or more if you follow the template. And look at the minimal loss because you know pneumo is a friend. Pneumo induces so much pressure that you just don't end up bleeding. It actually makes the surgeon look far more beautiful than he actually may be. But then you are surely going to use technology in today's era. So that's the right operator fossa, external iliac and the internal iliac template being dissected off. And a similar step is repeated on the opposite side for the lymphadenectomy because the lymphadenectomy is done on both the sides because the prostate is a midline organ and drains into both the templates of the iliac area. The prostatectomy has already been done. I've shown the video after it is removed. Look at the beauty of the anastomosis that one can do. These holes are just the tip of your thinnest finger. And you can take 10 to 12 throws through barbed sutures in a bloodless field. And the DVC is tied over here with the robotic reach. In a good hands, in DVC when we used to do open surgery, we would easily end up losing 1 to 1.5 liters bloods. And now you can see that I've not given a transfusion over the last 10 to 12 years of my journey of 1700 robotic cases. 3 transfusions in total in prostates. So you can do a watertight anastomosis, you have a small bladder neck and the patient is completely continent. For paucity of time, just we'll move on to the next one. What about the kidney cancer? Contrary to the belief what people feel in urology, the most lethal is the kidney cancer. 55 to 75 common stage of presentation. And it's increasing because you know most of us end up getting an ultrasound done just like a health checkup nowadays. And unfortunately, despite ultrasound, we are detecting kidney cancers early, yet the mortality has continued to rise. Possibly tobacco is a cause. Obesity is accepted as a major cause of a lot of cancers now due to the metabolic syndrome. Hypertension is the third major causative factor. A family history of kidney cancers, end-stage renal disease, and regular usages of painkillers due to the stressful life contribute to. The prevention strategies could include, again, healthy, balanced lifestyle. The older kind of diets that our elderlies used to eat, vegetables, more fruits, more grains, and lean proteins, more water, and control of blood pressure and diabetes at a proper time in life. And possibly reducing exposure to harmful substances like asbestos, cadmium, organic solvent helps. Surgery, even today, continues to be the primary treatment for all kinds of kidney cancers. And what would you offer? A partial or a complete removal? And why a partial? Because it preserves your glomerular filtration rate. For your knowledge, if you are able to preserve 20% of a single kidney, you will not end up being on a dialysis. With the diabetic epidemic catching up in India, with we being the diabetic capital of the world, with hypertension, you would rather have more GFR because this also reduces your heart attack rates. Now just let's look at how a partial nephrectomy is done beautifully with the robotic endodexterity. I'm catching the action from the time I clamp the arteries and the vessels. This is the tumor being cut over here in a bloodless field, of course, with a 15 times magnification. And the stitch. Look at the wrists of the instruments over here. Unlike laparoscopy, they actually mimic your wrist and fingers. So robotic surgery actually is done at the wrist and fingers, while a laparoscopy is done at shoulders and elbow joints, because the degree of freedom of movements is not there at the wrist. So the pelvic elation system is being closed over here, so that there is no urinary leak. This is just a half a centimeter area, which can be seen under magnification and controlled and closed actively. And then the kidney is being brought together primarily without the use of any high-tech gadgetry or sealants, because when you stitch something, it's gonna hold. This is a complete replica of open surgery, as one would like to do it in open. And in my early stages of the curve, I used to put some sealants because raat ko neend theek aati hai. So bladder cancers. The average mean age of diagnosis is 73 years, and they can be two types: non-muscle invasive or muscle invasive. So that means superficial and deep. Painless intermittent hematuria. Someone comes to you in your clinic, he says, "Khoon aaya tha peshab mein, dard nahi hua." It should set some alarm bells ringing. And urinary frequency and urgency along with that. So primarily, how do you diagnose? You do a biopsy, you do a cystoscopy, you do urinary cytology. Basically, you peep in and look with a telescope. For a non-muscle invasive cancer, yes, you can do an endoscopic treatment that's called transurethral resection of bladder tumor. And most of the times it suffices with intravesical therapies through BCGs, mitomycins, and gemcitabines, depending upon indications. For a muscle invasive, however, you need to go to the biggest extirpative surgery, that's called radical cystectomy, where it's a lifestyle changing surgery because you remove the entire urinary bladder. Patient may or may not need chemotherapy here. Sorry, sir. So, regular follow-up cystoscopies and urinary cytologies are done. And the biggest thing, stop smoking. If you can't stop smoking, you might as well not have a bladder cancer treatment.
What about drinking?
Oh, chalta hai, sir.
Menstruate chalta hai.
Social drinking chalta hai. Then I have just this posted this review and published this one, the learning curve of robotic radical cystectomy vis-a-vis open radical cystectomy. Anyone who's a master at robotic surgery still needs another 30 odd surgeries to master intravesical divergence. Intracorporeal divergence, where you even create the divergence like ideal conduits and neobladders through robotics. However, the robotic cystectomy carries an advantage over open cystectomy in terms of shorter operative times, lesser blood loss, and quicker recoveries. And the learning curves, as I said, can vary from 9 to 50 cases, and even for intracorporeal techniques, it may go up to 130 cases. So this is how a bladder cancer surgery would look like. Again, you're picking up the left ureter over there, slinging it off so that you do not handle it with the harsh instruments. Be gentle. The ureters are being clipped and cut. That's the bladder over there. That's the rectum. It is the caudal end of the patient. And again, a DVC is beautifully handled. Even Patrick Walsh, who's been the father of open prostatectomy, says, 1.5 liter ka blood loss ho raha hai, you're doing a good job. See, there is no blood loss because you've tied the DVC because of the reach of the instruments. Look at the urethral stump that can be taken out in front of the prostatic apex for a good intracorporeal neobladder inside. So almost 1 to 1.5 centimeter ensures a continence. The bladder is removed and look at the clean field. So we at Amrita now have the state-of-the-art molecular and genetic testing lab. We can test BRCA1, 2 and HOXB13 for patients. Will define whether this is going to come back, whether this is going to be aggressive, and what is the prognostication of the patient. These kind of labs are rare in our country, and they come in only a couple of places. We have the state-of-the-art lab already. For hereditary kidney cancer, you can have a VHL gene testing. You can have next generation sequencings like FGFR3 for bladder cancers that offer the patients targeted therapies when they have lost all hopes. So I'll show you, this is something very interesting that you need to see. We are left with some time? 1 minute. So this is an open retroperitoneal lymph node dissection that I've done. Entire abdomen stands exposed in a 17-year-old boy. for a testicular cancer. And then I went on to replicate it robotically. This was the first surgery done robotically anywhere in the world 11 years back. That's there on the YouTube on my teaching channel. So this is how the ports go. I'll just shorten it up for you because of paucity of time. So see, look at that. That's the aorta. How we can play with the aorta on the vascular sling. And on the right side, that's the IVC held in one of the instruments, and all lymph nodes being taken out amidst the IVC and the aorta. So this was the first case that we did on December 7th robotically in Amrita. A 114 kg lady, morbid obesity, single kidney, post-open pyelolithotomy, intrarenal pelvis for a pyeloplasty. And this day stays special in my heart because this was the birthday of my son who is presently in a hospital. And that's how it looks after the surgery. You can't even see the stitches. So a ureteric knee implantation, if you just wish to have a look. Ureteric stricture post ureteroscopies nowadays, and see how beautifully we can cut the ureter through the robot, and with the 5060 suture do an intricate suturing over there as if someone is doing zari work on a sari.
You just conclude now.
10-15 seconds, I'll just go to the last slide after this. I just want to show a few stitches in this. So that's the bladder mucosa. So you can see the dexterity and the way the stitches can be taken. It's a 6-0 stitch being done, almost like a hair thickness. And one case, this is the second case in the world that has been done robotically, a male and a female together. Staying with his wife, came to know that he's got a uterus inside and ovotestis. So I've done this just 4-5 months back. He's adopted a child and they're living as a happy couple together. The uterus and the cervix is being taken away from the seminal vesicle, and the seminal vesicle is stripped and reconstructed. He has normal erections, some ejaculate, and obviously he's infertile, but he's adopted a son. So I think that more or less sums it. And this is my YouTube teaching channel where almost 700 surgeons have subscribed, and I've put in almost 60 odd videos in case someone wants to have a look at the robotic surgeries.
Thank you so much, Dr. Ahmad, for an excellent presentation. And you now move on to the next session. You have 10 minutes. Dr. Kamaal, you can just start talking about your program and the type of work that you're doing before your slides are coming.
Thanks for the opportunity. Now, at Amrita, we have recently established a renal transplant program, but we are able to perform various complex cases like ADO-incompatible transplant in obese patients, but still waiting for other things like swab. And cadaveric plus also, we have done one. We received one cadaver recently and were able to do that. So, okay. So, we all know that CKD is a very common public health problem, and almost 175,000 patients require dialysis in India almost every year. That this pool is added, and the prevalence of CKD is around 17%. So we all know the definition of CKD stage 5 who is requiring dialysis. That is the patient, the GFR is less than 15, is a generally accepted definition of end-stage renal disease. So, first kidney transplant was performed in 1952, and then it was between identical twins. Then in 1959, allogenic kidney transplant between non-identical twins was performed. And then it's, we all know that it's now established that it's the most optimal form of renal replacement, whether in terms of patient survival, or quality of life, or cost effectiveness. So if we see the graph, if we see the patients who are on dialysis, if this is the reference, and then we see a patient who is undergoing kidney transplant. So initially there may be a little higher risk of infections and even death. But after 3 months, you can see this risk is keep on decreasing and decreasing. So the patients who remain on dialysis has got a higher risk of all the comorbidities and death because of being on dialysis. And this data is from a cadaveric kidney transplant. This is now most of the transplants being done are live donor in India. So I'm sure the result will be far more better. But we don't have this big study to support as evidence now. So what are the various etiologies? It includes diabetes, hypertension, cystic diseases, glomerulonephritis, IgA nephropathy, various congenital anomalies. So what are the contraindications of the kidney transplantation? So these are like metastatic cancer. Like patient is not expected to survive or is expected to die because of some metastatic cancers. Or there is some ongoing or recurring infections which are not treated. Or there is some serious or cardiac abnormality, means in a way that the patient is not expected to survive long. If hepatic insufficiency, which may require a simultaneous liver kidney transplant. There may be serious conditions that are unlikely to improve after renal transplant. Suppose the patient is found to have a very high pulmonary arterial pressure. So these patients don't, sudden cardiac death is very common. So these patients are usually not taken for transplant. So, and then the repeated episodes of non-compliance. Patient is not ready to take the medicines or immunosuppression in a post-transplant, then these patients are also not acceptable for kidney transplant. Or inability to perform rehabilitation. Patient is not able to take care of himself, he is not able to take drugs, then these conditions are also assessed preoperatively and usually they are denied transplant. Even there are some contraindications for immunosuppression, which is required for kidney to maintain to work. This was like HIV seropositivity, nowadays not absolute contraindication, provided it's well controlled, CD4 count is more than 200, HIV, RNA is undetectable, and patient is at least on ART for 3 months. So malignancy, the recipient, is again an important topic in itself, and we have to wait for about 5 years before taking a patient for transplant. If she had some breast cancer, or colorectal cancer, melanoma, or diffuse bladder cancer, ovarian cancer, because the risk of recurrence of these diseases is more than 50% in 2 years. If you perform a transplant, then there is no use of performing such a major surgery, and again the patient will succumb to his own diseases, and it's a graft loss. But some few small diseases like an in situ malignancies or a low-grade bladder, low-grade prostatic cancer, they are no more a contraindication for a transplant because they can be treated as normally as in a normal transplant, a normal patient. And poor social support, substance abuse, intractable financial problems can also compromise the post-operative management and immunosuppression, which contraindicate transplantation. But the risk of recurrence disease, many patients would ask, Doctor, what's the chance of disease recurrence? So they are absolutely, the glomerulonephritis, like the IgA nephropathy, they are most likely to recur. And FSG is known to occur in at least 30% of the patients in first transplant and 85% of the patients in second transplant. So there is a risk of recurrence, but even diabetes is known to recur. Even after 4 years, there will be some changes in the new kidney. But still the quality of life which you are going to give to this patient is definitely far more superior what you can achieve on dialysis, and that will justify your kidney transplant. So what are the patient and allograft survival after transplant? So if you see the scientific registry, the overall 10-year survival is around 50 to 60% of and the allograft, this depends on an allograft source also. Like for recipients of live donor kidney transplant, there is survival rate of at least 5 years post-transplant is more than 90%. But if you see for the same thing for the deceased donor is around 84%, and for those with the extended criteria donor, it just decreases to further 70%. If we see the patient kidneys received from less than 1 year or more than 65-year-old, they have uniformly poorer prognosis in deceased donors. And if we see the comparison of the of renal transplant recipient survival according to the months of dialysis. So this slide tells the importance that patients should not be kept on dialysis for a long time. If you see that the longer is the duration, the survival decreases. By the months, the dialysis, as the duration of the dialysis is increasing, the survival decreases. Okay. So I think I will give just if a broad idea is given. So I would like to conclude by saying that I'm left for 1 minute, 2 minutes? 2 minutes, okay. So I would like to conclude now because long slides and so if anything is there, I think they would ask. And so take home message would be like kidney transplants is generally the optimal form of renal replacement in terms of patient survival and quality of life. Immunosuppressive treatment is necessary for lifelong, and blood group compatibility is desirable, but it's not absolutely necessary because we are able to perform ABO compatible transplant routinely these days with same survival, same result as with a ABO compatible. And a live unrelated transplant with a complete HLA mismatching has a better long-term outcome than a cadaveric old organ or no mismatch at all. Thank you.
Thank you so much. We'll begin with the question answer sessions now, and I'd like to take the first opportunity to take the questions. And I'll first address the question to you. So, broadly, if I look at it, there are four kinds of transplants that I want to ask questions about. One is the ABO compatible, then the ABO incompatible, and then the cadaveric. In terms of survival and in terms of
I would say that we have around 7 lakhs, I would say 6 to 7 lakhs. So this includes the pre-operative workup as well as immunosuppression, which is given at the time of transplant.
And what is the 1 year survival or acceptance?
It's more than 90%. It would say like 1 year is 95 at least, 5 years is 90% at least, more than 90%. ABO compatible live donor transplant.
And when we move to ABO incompatible, does that change?
Incompatible is same for the live donors, and even the rejection and all are the same.
Cost is also same?
Cost is higher because they need either some plasmapheresis or means column, which is cost itself 2.5 lakh to 3 lakh. It depends on the titer. About if the ABO incompatibility, the titer is very high, then you need to give more plasmapheresis on this.
So how much would be an average cost for an ABO?
It would be around 8 lakhs at Amrita, I would say.
Right. And when you move to cadaveric, how does that change in terms of survival and cost?
Survival is definitely less in cadaveric because, but immediately if you say the 5 year survival, it would be definitely 80%, I would say, because whatever patient they have done, the creatinine has been at 1 at the discharge, and I have done even a dual kidney transplant to the same patient. It was at the time of COVID when we got a call from AIMS itself, and everyone refused that kidney. Patient had 80 and creatinine was 2, and still we got one male patient. And we transplanted both the kidneys in same patient, and the patient is doing absolutely fine. The creatinine is 1 still.
Fantastic. My questions to you, Dr. Malhotra. Now, with robotic surgery, the first concern that comes to mind is cost, always cost. And the second is the prudence of doing robotic versus probably a simpler laparoscopy. So where would you put the finger on absoluteness in terms of doing robotic versus laparoscopy? And what would you entail would be the difference in cost in general between procedures that are done robotically and laparoscopy?
So having established the entire urological cancer programs at Medanta over 13 years, I can tell you, with Amrita we have had an advantage. The hospital has had an infrastructure of 6,000 crores already, and with the MUT having the concept that they do not wish to recover the seed money, and they only want to have the running expenses from the hospital. So most of our robotic surgeries would be at 50% of the cost of any premium hospital in Delhi NCR. Moreover, we have a state-of-the-art Da Vinci XI robot. Say, for example, if a prostatectomy, I would not name the hospital, if it is done for 6.5 or 7 lakhs at any other hospital, it would be done for 3.8 lakhs at our hospital. So say, for example, a robotic partial nephrectomy that's done for 7 lakhs at any other hospital would be done for 4,10,000 rupees or 4,20,000 for 90-95% of the patients who would subscribe to the standard. And for cystectomies, when there are charges to the tune of 10 to 13 lakh rupees, a patient at our place could be between 6 to 7 lakh rupees. As far as the absolutes are concerned, so any reconstructive surgery or whichever demands suturing or in-depth surgery would surely entail going on to the robot first. So the entire argument was based on the cost thing. So if you take away the cost, no one would mind going on to the higher end of solid technology. And at Amrita, I'm fortunate to have the cost factor out from my life. Because what is the charge for a laparoscopy in a premium hospital is the charge for robotic in my hospital. So I would rather offer robotic to every patient at my place.
Wonderful. So I'll now pass it on to Dr. Shubham for the next question.
No, just a minute. Once we finish the moderated questions for Euro, we finish the moderated questions for Hepato, and then I come to you.
Thank you so much, Sushil sir. My first question to all three of you would be very normal questions which a physician would think that when I was doing my DM, basic dictum was that if a patient is an alcoholic liver disease and he's not drinking for 6 months, only then I would offer him a liver transplant. Does that stand true in a in the private sector in today's day and age? And along with, please enlighten us with the cost which a liver transplant, live donor liver transplant would cost. Anyone of you can take that question.
So for alcoholic liver disease, for listing a patient in the national list, the disease donor list, the note still follows the 6-month abstinence rule. So for cadaveric donation, we need the patient to be abstinent for 6 months. But for a live donor liver transplant, if the psychiatrist clears the patient is motivated enough, and we still follow minimum 3 months. So if 3 months he is abstinent, then we go ahead with the transplant. Sometimes the patient may be too sick. He may be in ACLF, acute and chronic liver failure, where his average survival is only limited to 28 days or less than 3 months. Then as a life-saving measure, if the family is motivated that the patient will not relapse, then we can go ahead with the liver transplant. And this dictum of 6 months or 3 months is also changing, because whatever relapse we see after liver transplant, the harmful alcohol use after liver transplant has been described in about 15 to 20% patients only, even when the abstinence rule is not followed. So we are moving against the abstinence rule.
What's the cost of liver transplant at Amrita Hospital, Faridabad?
Cost for liver transplant as such as a package, which is for 3 weeks for the recipient, about 1 week in the ICU, 2 weeks in the ward, and donor of about 3 days in the ICU and 5 days in the ward. It's about 16.5 lakhs for open surgery for the donor. Recipient surgeries are always open. If the donor surgery is open, it's 16.5. If it's robotic, it's 2 lakhs costly because all the instruments are disposable, so 18.5 lakhs. The pre-transplant workup is not a part of this, it's about 1 lakh extra.
So about 19.5 lakhs in total?
Yes, yes.
So I wish to make a comment over here. And the same for other premium hospital goes anywhere from 28 to 45 to 50 lakh rupees.
Yeah, we are aware of that. So that's that.
Cadaveric cost is 19 lakhs. If we list the patient and they get an organ, it's at 19 lakhs right now.
Thank you for the update. And the second thing would be a chronic hepatitis B patient who's on entecavir or tenofovir with documented 3 years of HBV DNA not detectable. What is the percentage chance of reactivation of hepatitis B on immunosuppression? The same would be for hepatitis C, but with hepatitis C we have therapy to eradicate hepatitis C in both the donor and the recipient, so that's fine. But I'm worried about hepatitis B as a gastroenterologist, not looking after liver transplant as such, but referring patients to multiple people in the city and maybe NCR with liver transplant patients, having a large patient population of cirrhotic patients. So I'm still worried with the multiple, even nivolumab and all these therapies. What is your experience with reactivation of hepatitis B with immunosuppression?
Rohit will be able to answer that question.
So if a patient is hepatitis B, HBs antigen positive and is cirrhosis and is undergoing a liver transplant, so the reactivation on treatment is, we haven't really seen. If the patient is not on treatment, then the reactivation occurs. But if somebody is already on entecavir or tenofovir, then I'm not seeing reactivation.
So you mean to say that if the patient is on tenofovir or entecavir in the post-transplant period with immunosuppression, the chances of reactivation are again negligible. So I think that's a very important message for the physician sitting here as well, that the patient will be hepatitis B even after transplant, but still he is a safe candidate if he has liver disease. Right, Rohit?
Shubham, can I interfere in this? One question, one general question, because I am a virologist and asking you a question. So with kidney transplant, we have 2 kidneys. And with the donor, we are usually, we are very safe and we understand the risk is not as much. But the concern always with liver transplant is you're taking away from the donor part of his liver. And there's a worry with the donor. One, how much is the actual risk vis-a-vis a kidney donor? And how do you counsel these patients?
So, obviously as described in the presentation before, the donor has to meet the criteria for being a healthy donor and being fit to be a donor. If they have met these criteria, so basically we are talking about their the age limit, they have no major comorbidities and their liver is good. So, liver is good, we are confirming by imaging it, doing 5-year scans and of course the liver function test. So if they are meeting all the criteria of being a healthy donor, then I would say that the risks are, they're not negligible, but overall if you're asking about a major morbidity, it will probably come between 1 to 2%. Maybe even less than that in larger numbers. Minor complications, yes of course, which can be managed very easily with medical management like minor bleedings, wound infections, etc. I think the major issue that we are concerned about is post-operative biliary leak, which again, more often than not, cut surface leaks settle on their own, and other leaks from the duct can be managed with interventional management like endoscopic stenting. So we're not really looking at a gross, very dangerous procedure, although it would fall under the category of a major surgery. Like Dr. Jaya mentioned earlier, it is a relatively safe surgery, whichever way we perform it.
So one last question, sir. So Rohit, BCIC stage B, patient having partial portal vein thrombosis. How fit is he for new liver? And is total portal vein thrombosis an absolute contraindication for liver transplant in today's day and age?
The PVT is tumoral. So in a tumoral PVT, ideally we would like the patient to be treated for PVT before considering a liver transplant either through TARE or SBRT. And then if we demonstrate that the PVT has responded to treatment, the HB levels are less than 1000 ideally and there is no extrahepatic disease on a PET scan, then they would be candidate for transplant.
So are the alpha-fetoprotein levels more than 1000 a contraindication for liver transplant?
Not an absolute contraindication, relative one, but if the levels are more than 1000 and there is no extrahepatic disease on PET scan, the chances of recurrence of NCC after a transplant are high. But still we would not totally negate that the patient cannot undergo a transplant.
Thank you, Rohit. We open the stage for audience questions, and I ask Sushil sir to help us with that.
I would request the birthday boy to ask his questions and be brief, because we need to celebrate his birthday.
Thank you, Dr. Chavan. And so the 5 speakers had wonderful, deliberations, and they talked about a lot of things which we didn't know much about. So to start with, Dr. Rohit, indications for liver transplant. So probably in US is the ALE, which is 32%, NASH is 35%, and hepatitis C 12%, and HCC 11%. What about India?
Right now in India, the first and the second, I would say, are alcoholic liver disease and non-alcoholic fatty liver disease, closely followed by hepatitis B and hepatitis C. The autoimmune, HCCs and viral and other autoimmune conditions, they are probably less.
So, Dr. Rohit, what about the survival after liver transplant? At 1 year, it's about 90%, and at about 5 years, it's about 80%.
Yes.
So same here?
Same survival. More than 90% at 1 year and 5 years close to 80%.
Wonderful. So, Dr. Jaya, you wonderful talk, and who can donate? You said age, sex, second and third liver transplant. Talk us through these 3 things.
So age is ideally between 18 to 55 years. The younger the donor, the liver regeneration capacity is better.
Yeah.
So we prefer the age.
What about sex?
Both the sexes can donate. There is no contraindication or advantage of one being over the other. But most of the cirrhotics tend to be males, and we've seen wives coming forward. If you see the actual ratio of donation, maybe females are donating more than the males, but there is no contraindication or advantage of one sex or the other.
Right. And Dr. Shweta, you talked about robotic liver transplant. Saudi Arabia and Korea are leading. Recently, Washington University had probably done a recent robotic liver transplant, and why are we so bad? And now this robotic transplant which was done at Washington University, at 7 weeks the patient was playing golf and swimming. This is just recently done, probably June 2023. Talk us through this, Dr. Shweta.
So, firstly, I don't think we are that far away. We are the second largest program in the world.
You said so? Yeah.
So, I don't think we are that far back away. The first transplant was done at our center in 2018. Since then, a lot of other transplant centers across India have picked up this procedure, and their numbers are building up. I am confident that in future this will become the method of transplant because of the benefits that it gives to a donor. Also, the cost might be a factor, but at our institute, I think we are fortunate enough to be able to keep the cost lower. If you can see, we mentioned before the differences of 2 lakhs, which for a far superior technology. So I think if we can bring the cost down, acceptability will be higher.
Great. So NAGM June 2023 talked about the potential new drug, which is the pegofetamine. It's a fibroblast, you see, drug factor 21, which improves fibrosis, inflammation, and acute liver injury. Just talk about through this new drug, the pegofetamine.
Dr. Rohit might be able to answer this.
So this drug has been used for non-alcoholic fatty liver disease and NASH treatment. So currently it's not available for market use in India. It's undergoing a phase 3 trial, multi-center trial.
24 weeks trial, phase 3 trial. So this seems to be a very promising drug.
Yes. So the evidence for use has not been replicated in the Indian population, and currently there is a phase phase 3 trial, multi-center trial from India, which is recruiting patients for this. So maybe in the next couple of years we'll have it for use in India.
Right. So my last question to Dr. Madhav would be, really this was an eye-opening talk, really wonderful talk.
Thank you, sir.
I really appreciate this. So robotics in urology, prostate, kidney, bladder, also talk about adrenals, do the pros outweigh the cons with robotics dramatically. Why? Because complex procedures can be done with utmost precision. You could go to areas where probably laparoscopic surgery or open surgery would not be possible. So talking about the RARP, just 1% were done in 2003. Now 2014, 90% of the RARPs are being done. What about at your center? Are you doing 100% of the RARPs?
Sir, 100% of our prostatectomies are robotic.
Wonderful. That's great.
I've been fortunate to have been trained in an era where we do open prostatectomies too. But
Would you also say anecdotally, probably the sexual functions and the incontinence probably are earlier when you do with the RARP?
there's an early recovery and a far higher recovery.
I have to end here. Thank you.
Thank you.
I think Dr.
You've been spared by the birthday boy, but you will not be spared by the best friend of the birthday boy.
Okay, sir. Best friend has a right to kiss anywhere. Sir, I want to say he will be probably cutting the cake with robotically. Sir, my very few questions. Sir.
I thought that was a French kiss.
Sir, liver transplantation. So, is fatty liver, what level of fatty liver is contraindication?
For a
donor.
So the degree of steatosis on the donor decides whether the patient can donate. So any degree of fibrosis in the liver is a contraindication. For
what level? Grade 1, 2, 3 is on the
if there is any fibrosis, then we do not consider the patient for donor surgery. The level of steatosis, it should be less than 33%.
So how we decide this on cadaveric donor? Do we find any steatosis there?
In cadaveric donor, sir, first when the patient is taken for the explant, if on visual inspection, if the surgeon feels that the liver is fatty, then biopsy is done from the liver, and then we get the results immediately like a frozen section, and then we take the recipient for the surgery.
Sir, about the comorbidities like diabetes, hypertension, so many others, controlled or uncontrolled, does it matter for a donor? And how does it matter? Will it matter if it is controlled in the donor and it's not controlled in the recipient?
Sir, control for the donor you are asking, right, sir?
Yeah.
So controlled, definitely. Uncontrolled comorbidities have their added risk as well as the anesthesia risks. So uncontrolled, definitely not for a donor.
Okay. Well, there was a statement about adoption and fertility. I've noted after adoption there is increased fertility. Thank you.